Muchos países alrededor del mundo
Many countries around the world have made a commitment to move towards universal health coverage. UHC means you provide all the health services people need with quality and without financial hardship for them. But we are far from reaching that goal. Millions of people have huge difficulties accessing the health services promised by their governments, or they have financial issues with access to the services and drugs they need. And this happens not just because of a lack of health resources, but also because of huge inefficiencies in the sector. About 40% of the resources are wasted for this reason. Can you imagine what could be achieved if we could reduce those inefficiencies? The massive open online course, What to Finance in Health and at What Price, deals with this challenge together with world experts on health prioritization, price regulation policies, and others. They have different perspectives and experiences, and they'll help you make informed decisions in health coverage and price regulation for drugs. And this will help countries move toward UHC and have better health for their populations. We invite you to sign up for this MOOC.
Muy buenos días a todas y a todos. To our
Good morning, everyone.
simultaneous translation, which you can access by clicking the globe icon at the bottom of your screen. Me da mucho gusto darles la bienvenida a este webinar. Mi
La
nombre es
pantalla. It's a pleasure to welcome you today. I'm Marcela Distruti. I coordinate the criteria network for the IDB, and I'm here today with my colleague Ursula Gideon. She is a strategic health advisor at the IDB. And we're very happy to begin this new series looking at a very important issue: financing high-cost medications. As you know, resources are finite. So when you fund certain health services, that means you're not funding others. And these decisions have important consequences for population health. We're talking about the opportunity cost of our decisions. However, these opportunity costs are rarely obvious when we are deciding what to finance or what to cover for our population. And there are not a lot of studies that have been done on this matter. So I'm very happy to be able to share with you the first results of the first two results of four studies conducted with the technical coordination of Catalina Gutierrez on the opportunity costs of resource allocation decisions. In these first two studies, we focused on the opportunity costs of financing high-cost drugs. The first study is on Colombia. Its main author is Catalina Gutierrez, and the second one about the Dominican Republic was led by Natalia Jorgensen. These studies are now available online, and they will be in the chat. The links will be in the chat. The English version will be available on our website in the next few days. And this webinar will be a conversation with Catalina and Natalia about the most significant findings of these studies. And then Javier Guzman will tell you a little bit about what he thinks about these results. And then we'll have a discussion with all of you. Before we begin, I'd like to briefly introduce our guests today. Catalina Gutierrez is an economist. She has over 15 years of experience providing technical assistance and advice to Latin American governments and international organizations. She has a PhD in economics from New York University and a master's degree in economics from the Universidad de los Andes. Natalia Jorgensen has a lot of experience in dealing with health policies in the region. She has been the technical coordination of the IDB project in Argentina regarding health benefits. She is now the director of a project. And Javier Guzman is a doctor. He is in charge of the international initiative for decision support and this is active in Asia and Africa. They offer evidence-based priority setting. So I'd like to ask you to participate by providing your questions through our guests' presentation, and you can use the Q&A icon at the bottom of your screens for this to send us your questions. So go ahead, Ursula. Thank you very much, Marcela. Hello, everyone. I agree with you, Marcela, on the opportunity cost issue. It is so important when we're making coverage decisions. And I might even dare to say that it is a matter that we've been ignoring when we conduct our studies and when we make decisions as well. What we're hoping is that when we hear what Catalina and Natalia are going to present today, you will get a taste of why we believe opportunity costs are such an important issue in decision making in this area. And it's not just a matter of saving resources, but actually providing better health for the population. And just changing the format a bit, what we've done is that instead of having Natalia and Catalina just give a presentation, we have opted for more of an interview type format so we can focus on the most significant findings. So without further ado, I will go on to the first question, which is for Catalina. Welcome, Catalina. It's such a pleasure to have you with us. And I'd like to ask you the following question. What was the motivation for these studies? What prompted you to conduct them, and what is their importance for the region? Thank you, Ursula, and hello, everyone. It's such a pleasure to be with you today. The main reason for this study was a concern that we had. We knew that new technologies are exerting a lot of pressure on public health budgets all over the world, not just in our countries. And this is in a context where we have reduced fiscal space, especially after COVID. We're seeing a tightening of conditions and less spending in general. So our concern was that there's an increasing number of countries in the region providing coverage for very high cost drugs, some of them with uncertain levels of effectiveness or reduced effectiveness with a very high budget that is needed for them. And some of these countries and some of these drugs do not have coverage even in wealthier countries than ours. So the concern is, as Marcela has already mentioned, these investments or the financing of these drugs is displacing health services that had been provided in other parts of the system. So our worry was, what is the cost? What are we losing out on when we are financing these drugs and not financing other services? When we started looking at what was known about this, we realized that there wasn't a lot of information for the region. This issue has been studied in other parts of the world, but for our country, it's basically no information that we have. We don't know how much these decisions are costing. We could be incurring extremely high costs without even realizing it. So that was what prompted us to conduct this study. Thank you very much, Catalina. I think you've already segued into opportunity costs, but since this is the main focus of all these studies, it actually would be a good idea for you to explain to us very briefly what we're actually talking about when we say opportunity costs, so we all have the same understanding. Yes, then let's show a couple of slides that I have that will help us understand this concept, which is sometimes not that easy to grasp. And Marcela said it already. When we finance some health services, this means necessarily that there are others that will not be funded. And this has consequences for the health of the population. Somebody always pays for these services that no longer have coverage. So an opportunity cost is that benefit that we might have received, but which we do not receive because we went a different path. We took a different path. So there are some concepts that we use in health economics to understand this. We talk about the net health benefit, which has a threshold for cost effectiveness. So I'll explain this briefly. The net health benefit is that net benefit compared to the other treatment. There's an existing treatment, something else comes along, it offers certain benefits. What is the net benefit in using this new and more expensive treatment versus the previous one, and what health benefits could be achieved if those funds, instead of using them for financing this more expensive treatment, were used other parts of the health system. So there are two components to this equation. You see years of life, quality adjusted life, versus years of life, quality adjusted of the alternative. So what are we measuring here with these quality adjusted years? 1 year of life is equivalent to a year of life that you live in perfect health. So if I have a medication that will give me 1 more year of life, but my quality of life is half, then that medication will provide half a year of quality adjusted life. That's how we measure those health benefits. So that first component is that net gain in health. And this information comes from clinical studies. And this is multiplied times the number of people being benefited. The second component is the health loss due to lack of investment in other technologies. And here I'll talk about that cost effectiveness threshold. That's that UCE abbreviation that you see there. And what is that threshold? It is the cost for one country of generating 1 more year of life in perfect health. The price of a t-shirt is $10. The price of one of these years of perfect health, that is the cost effectiveness threshold. So how do I calculate what level of benefit, what amount of benefit I could gain, what I lose by investing those resources that I need to invest into that high cost medication? What do I lose elsewhere? So I look at the cost of that high cost medication minus the cost of the alternative. So the difference in costs, those are the additional resources that I will have to invest in order to finance that high cost medication. And I take that out of the health system in some way. What could I buy in the health sector for that cost? So that amount of resources is divided by the price. I have a budget, I divide it by the price of each t-shirt. That gives me the number of t-shirts I can purchase. That's what I have in that formula. So that's how we measure that net health benefit, the cost of the medications, the number of people receiving the service. This we get from the data of the countries themselves. We also have international clinical data, and that threshold comes from very rigorous previous studies that were conducted for both countries. Is that it for this slide, Kata? Yes. Okay, let's go on to the next question then. When we design these studies, we talk about this methodology, this approach that you just described, and we use that cost effectiveness threshold. But there's another element there where, in addition to this approach that you described, we used another methodology as well. Can you tell us about it and tell us why we decided to use it? Yes, this was very enriching and interesting discussion, and it led us to a conclusion, a result that's very important for the region, I think. So let's go back to the previous slide, and I'll tell you a little bit about what this discussion covered. When we looked at the standard methodologies to calculate opportunity costs, we realized that these were designed for countries without significant gaps in essential services coverage. These are very cost-effective interventions, very low cost, that give us excellent results. Diabetes control is one of them, and screening for cancer is another one. And these, of course, mean that there's a very high gain in health based on these small investments. So that's the average cost that a country pays for one quality adjusted life year. So if it's $10, then that's the threshold. So in countries where we don't have that large gap in essential services, you don't know where that investment will be withdrawn. We don't know exactly how that adjustment will take place in the health sector. So using the average price makes sense, assuming that withdrawal of the investment happens all over the system. But in our countries, we do know that we have gaps in essential service coverage. We know that with those resources, we could cover those gaps. So what we realized was that the relevant question for our countries was, if I devote those resources to those gaps, how much can I gain in health compared to what I would gain if I cover the high cost medication? So we started thinking, if we wanted to estimate that, how would we do it? What is the methodology that we should use? Because I think that's the relevant question for our countries. And that's what we did. In the Dominican Republic, we find that there's an underestimation of the threshold if we do it that way. The real cost is the coverage of those gaps. And if we look at it from that perspective, we get an opportunity cost that is 4 times higher. So that's a very important result of the study for countries where we have those big gaps and we need methodologies that are appropriate for those conditions. Thank you very much, Catalina. Now we're all anxious to know what the results were of the studies conducted in the two countries. Do you want to tell us a little bit about that? Yes, we can go on to the next slide. So what did we do? We're not talking about specific medications. What we did was to look at just a sample of high cost medications because of the budgetary impact of these medications in each one of the countries. These were high, they were taking over a significant proportion of the resources, or because the cost per patient treated each year was very high. And we took other elements into account, but those were the basic two criteria that we applied. And for the two countries, if we use those two criteria, we got a sample of 10 medications. You see the numbers there, but we don't see the headers, unfortunately, of the columns. But what I just wanted you to see was that basically we calculated each one of the elements of that formula I mentioned, a difference in benefits in quality adjusted life years. We calculated the difference in cost between the medications, the number of people treated, and the net benefit. The number you see there highlighted in blue is the net health benefit that in this case is negative. And the 10 high cost medications, what we found is that they provide additional benefits that go from 2 weeks of life. Some of these medications provide 2 additional weeks of life throughout the course of the treatment for a person. 2 weeks up to a year and 6 months of perfect health, with a cost, in the case of Colombia, of $543 million for the health system. And this is for 23,000 patients. If those additional resources that went to these high cost medications had been used to provide better access to medications with average cost effectiveness, Colombia could have achieved 88,000 more years of life in perfect health. So these are significant numbers. And the gains and their significance can be judged by you, and we see that these high cost medications have limited benefits net benefits that they provide. Here is the case of the Dominican Republic. The 10 high-cost medications provide benefits that go from 3 months up to a year and 10 months of life in perfect health for the entire duration of the treatment, with a cost of $154 million. And this is for 1,807 patients. And the medications that we saw in both groups, they're different, of course, because the costs of the medications are different and the number of people treated is different. But if the resources allocated to high-cost medications had been used to improve the rest of the service, then 35,258,000 years of life in perfect health would have been gained. So these opportunity costs are significant. We're talking about 35,000 years of life in perfect health because we want coverage for 10 medications for the entire duration of the treatment of these conditions that are being treated by these high-cost medications. Next slide. And then the result that the finding that I thought was the most interesting one was what else can we look at with this using this methodology? Let's estimate if the resources needed to finance these high-cost medications in the Dominican Republic, if they were used to cover two gaps in essential services. The first one is a timely screening of cervical cancer through a pap smear or other very low-cost interventions. And then there's also detection and management of diabetes in adults at risk. This is not even medications, it's just the management of diabetes. And their findings tell us that if we use the resources for those high-cost medications for this, instead, we could cover 100% of the gap in cervical cancer screening and 46% of the gap in screening and management of diabetes. And we would gain 127,887 years of life in perfect health for the country. So that's almost 4 times what you would, the number you would get if you use the threshold method. So those were our findings in this regard. Thank you, Catalina. I think you've presented a very clear case that we should at least take this opportunity cost element into account in decision making. We all agree it's not the only criteria, but it should be one of them. Natalia, hello. A question for you now. We saw that the findings are quite impressive, but there are also some complexities. How feasible do you think it is that this type of calculation and the threshold method will become something that's done routinely when decisions are made about health coverage? Well, undoubtedly, if we want this to be done systematically, we need to invest in the infrastructure that in terms of data that we need. We still have some information that we lack in our countries to do this systematically, but we also should say that the countries do have data. These come from invoicing mostly. We were analyzing the high cost medications and we saw prices and quantities so we could estimate costs, and we saw that this was in fact available. And when you move on to essential services and try to estimate what these gaps are that Catalina was talking about, it becomes much more complicated because you need to estimate the need and estimate the use for each one of these benefits, these goods and services that are a part of that particular intervention. So in order to move forward with these estimates, we use data from different sources. We used national and international sources. We used data from surveys and at the local level, and also from international databases to calculate need. And we use some registry data from the ministries to estimate use rates for each one of the benefits included in these baskets of benefits. So there are difficulties that we face regarding the quality of this data, of course, but we need to bear in mind that to the extent that we use them, as we use them and show the importance of these types of data and generating this information systematically, and this was made very clear by Catalina, then when this is made clear, then I think we will see some improvements in our information systems and we will be able to have better data. Another important thing here had to do with the cost effectiveness ratios that we needed to for these estimates. What we used were international databases. We have the Tufts database it's a repository of information that also assesses the quality of the studies that have taken place regarding cost effectiveness in the last 20 years. And we also used something else. Dan and his team, Dan Allendorf and his team worked with us to help us adapt these incremental ratios that are in the literature for other countries and for other years, and to adapt them for the Dominican Republic and Colombia so we could calculate those estimates for the local population. Here we need to bear in mind that when you use this type of information from a variety of different sources, perhaps the quality is not the best. So you need to conduct consistency analyses. You need to do a full analysis of the entire process. And you have to use your common sense when you look at the results as well, through the screen of common sense, so to speak. And that's what we did with these varied sources of data so we could achieve those results that Catalina was referring to. Thank you very much, Natalia. That was a very clear answer. You showed a lot of creativity and willingness to collaborate with experts. And that leads me to tell you that we have a surprise. We have Dan with us, and he will tell us very briefly how he sees this. Dan Ollendorf, I think you're all familiar with him. He'll tell us about the significance of these studies from a more general perspective.
Please go ahead with your comment on the relevance of this kind of studies.
Thank you, Ursula, and thank you all for inviting me. It really was a pleasure to be able to work with Catalina and Natalia on this effort. It really does highlight for me a number of challenges that we face in trying to understand some of these questions. Clearly, you saw the data that both Catalina and Natalia spoke about. It is important to remember that we are talking about two upper middle income settings. So these are settings in which you might think on the face of it that full investment in essential health benefits and established cost-effective medication should already be the case, but we clearly see that that is not the case, and that funding for high-cost therapies for very specialized or in some cases rare disease are affecting health in a number of negative ways. And this is certainly not something that is specific only to Colombia and the Dominican Republic. We also face issues like that even here in the US. Certainly the COVID pandemic highlighted for us that the lack of investment in our public health infrastructure was costing lives and diminishing quality of life, while we were spending what we pay on these drugs, the highest prices in the world, for these very specialized therapies. One of the other things that this effort highlighted for me is that it really should be very easy for decision makers in low and middle income countries to access information on the health benefits that essential benefits and other services provide. but it really is difficult. It took a very intensive research effort on the part of Catalina and Natalia and their teams to really generate the information necessary to inform this conversation. So along with the discussion, there really is a call to create a publicly available data bank that would have information on the health gains associated with established services and essential benefits, so that any decision maker, when thinking about their own benefits package, can understand the trade-offs associated with investment in a potential high-cost therapy for a limited or specialized area relative to the essential benefits that might be more beneficial on a population-wide basis. I do also want to make mention that along with that call for public data, Natalia mentioned the cost effectiveness database that we maintain at Tufts, which now includes over 13,000 studies, published studies focused on quality adjusted or disability adjusted life years as the measure of health gain. That database is now available to any individual researcher or institution in a low or middle income setting for free. So please reach out to us to ask questions about accessing the data. And so that is at least one effort to try to make the data available. The other data set that Natalia mentioned was our database on quality gains, which is focused specifically on measuring the health gains between comparative treatments. That is a very difficult database to really scale because the availability of different treatments and different comparators is very different by country. And so a lot of additional effort was required to really understand the gains that are associated with these specialized treatments. So again, there is an opportunity to try to make that kind of information publicly available and accessible as well. So thank you again. It was really a pleasure to be part of this effort, and I look forward to seeing how the work is carried forward in the future.
Muchas gracias, Dan. Creo que ahí hubo un llamado también como a la comunidad global.
Thank you, Dan. There was a call to the global community to think very well about the type of data that can be useful for the decision-making process and to analyze the trade-offs and when a decision is made about what to cover and what not. Now, I would like to offer the floor to Javier Guzman. Go ahead, Javier. The floor is yours. Thank you, Ursula. First of all, I would like to thank you for your invitation. It's a pleasure to be here. Congratulations to the IDB, Catalina, Natalia, Dan, and you for this very interesting effort. The first thing that I would like to say is that it's very important to quantify this opportunity cost. The opportunity cost is mentioned constantly, but to have a figure, to be able to quantify it is something very powerful. It shows the importance of the continuum of the prioritization system. When we talk about Colombia, the Dominican Republic, if we ask, is the VPH vaccine included, the HPV vaccine included, or for example, high blood pressure? Yes, it's included, but that decision-making process in terms of coverage doesn't mean that that type of service, that type of intervention is actually reaching the patients that need it. Therefore, access, monitoring, evaluation of coverage is lost in our system. That's why what's been said is so important. I believe there are 4 reasons for which we are seeing this situation. 4 reasons and were actions in order to overcome these challenges. The 4 reasons. Well, we don't have explicit regulatory frameworks regarding the mandatory nature to include the opportunity cost in our systems. In fact, in Colombia, this was actively excluded from the system. This is very problematic, but many countries are now discussing their legal framework, and we should discuss the mandatory nature of it, not to have an automatic response, but to really include this opportunity cost in the decision-making. Another thing, unless you have this legal requirement, there's no conversation about the social contract. What do we need to buy with the money we have available? How much money we have for health? What is the threshold for the cost-effective nature of it? Now, the second reason why we see these type of problems is because the systems are not structured in order to consider a single health cost. In the case of the Dominican Republic, we see something very interesting. They have the benefit plans on the one hand, and also on the other hand, an account to pay very costly drugs. And this shows that the opportunity cost is very difficult to identify in terms of health as a whole. And this really creates problems when you're trying to implement solutions in order to improve the benefit in terms of health, for example, joint procurement, or improve cost effectiveness in order to reduce prices. The third problem is that we don't have data. You said it. There's no information regarding coverage. The information that is there is not used for the decision-making process. There's no information about cost effectiveness, the price of those public databases, bases. And now the final project is that stakeholders in our health services are concerned about their own diseases. They're supported by the industry many times. Other times, there's no transparent discussion about how much money we have, how it's going to be used. Many times, the legal framework, in fact, favors these minority groups. And I think it's good to have a discussion about that balance between efficiency, equity, or how we prioritize that value in terms of health benefits for our population. Taking into account these four reasons for the challenges that we're facing, for me, the solutions are: we need to have a discussion about the legal framework and the social pact in the countries that have not had it, and those are discussing reforms to the health system. And we need to talk about how much we are spending in health in our countries. In Latin America, we spend $1,100 a year per person. What can we buy with those $1,100? The population in our country believes that there's much more money, and the money is either being stolen or someone is becoming very rich. There's no awareness that we have limited funds available. And of course, part of the conversation is how do we increase those $1,100, but also how do we make them more efficient? We need to have that conversation. Second, we need to have a transparent discussion. Whatever we discuss has to be explicit about the opportunity cost and how important it is to include in the decision-making process. This continues to be something academic. The decision makers, the doctors, the patients associations, experts associations do not include the opportunity cost in their discussions. And I think this has to be demystified, and it has to be put in very simple terms, as Catalina did, saying if you put $1 here, you're not going to put it here. And the health budget is a single budget. How do we do it so that the budget is really invested in the best way possible? This takes me to the third solution, which has to do with the following. The system has to be reformed so that the budget is a good budget. What do I mean by this? We saw it in Benelux. The Netherlands had insurers that bought directly to their affiliates. But when hepatitis C started in the country, they realized that they needed to join all the different insurers in a single negotiation pool. So how do we do to improve the structure in our systems, to improve the negotiation process, to make sure that that cost effectiveness is taken into account, and to make sure that we have fast lanes to improve also competition? How do we do joint procurement in order to have better negotiation capabilities? Something that is important moving forward is the following: uncertainty regarding health and cost effectiveness is only going to increase. And it is increasing notably because agencies such as the FDA are approving all the medications with less information than before. And they have the possibility to see how the drug is performing in the market. We are making decisions based on that information at a very early stage of the drug. We need to be ready to manage this uncertainty with flexibility and to collect data about effectiveness, use, and then analyze shared risks and see that if there is no performance, then we won't pay. It's important to have an information system that includes issues such as coverage, effectiveness of key medication. You cannot do that for all of them. You need certain tracking information, and it needs to put on the table information about the exchange of monies basically among the different stakeholders and how the industry could be funding patients associations or experts associations that are interested in a specific drug. Ursula, those are my 4 problems and my 4 solutions. Thank you very much for your invitation. Thank you, Javier. Brilliant. We didn't really plan it that way, but Catalina and Natalia talked about the methodology, why, the results, and you did an analysis, a policy analysis, and also you offered very specific recommendations. I hope a policy brief comes out of it because it was really excellent. Now I would like to offer the floor to Marcela so she can moderate the Q&A. Marcela, the floor is yours. Go ahead. Thank you very much, Ursula, and thank you everyone for thank you to the panelists, the speakers, because this session has been truly interesting. This is shown in the number of participants that we have in this session, as well as the number of questions that we are receiving. I'm trying to organize the questions, but I wanted to start asking Katarina and Natalia to talk a little bit about what countries can do in order to reduce the opportunity cost of highly costly drugs. There are several questions related to this. So what are some of the alternatives for the countries themselves? I think Javier mentioned very important issues, but I think we need to highlight 3 things. The first one, we need to formalize the inclusion of the opportunity cost in the decision-making process. We need to bring visibility to this, what we are paying in terms of life and quality of life to cover these drugs, and that cannot be put under the rug. That involves our health agencies, and it also involves strengthening of institutions and information sharing. The second thing has to do with pricing. One of the questions that I saw was that why one of the drugs that was studied for Colombia provides such a positive benefit. We are talking about price differences that may be small, but that increase exponentially when we look at the number of patients that are being treated. So the issue of pricing is very important. If we compare this to another medication, which was the best available alternative to pembrolizumab, one provides benefits, but not the other, additional benefits, but not the other. So it's a matter of pricing. These estimates, these calculations rather, are very sensitive. We analyze some medications, some drugs with a 20 or 30% discount regarding the average registered price in Colombia, and we started to see opportunity cost of 0 or null. So managing prices so that we don't incur in these costs is truly important. And Javier mentioned some of the mechanisms to establish prices. And the other issue is that if some drugs provide clinical benefits that are very reduced, very limited, for example, 2 weeks of life in perfect health throughout the entire treatment for very significant opportunity cost, I think as countries, we need to decide if we're going to cover or not those medications. Those are the three topics that need to be addressed. Are we going to cover those drugs or not? Are we going to manage prices in a more effective way so that we don't incur in those opportunity costs? And then we need to see how much we are spending in terms, or rather how how costly are they in terms of lives and quality of life. Natalia, do you want to add something? No, I think you've explained it very well. Thank you. There's a very interesting question here about legalization. The question is there space to take into account the opportunity cost in court to assess this type of issue? I don't know if any of the speakers would like to talk about this issue. If you want to, I can provide one answer, but I'm sure everyone here can contribute to the answer. In Colombia, Colombia is one of the countries with more legal issues in this regard. There's no international legislation, no international agreement that says that we have to cover everything for everyone. So regarding the law, all regulations recognize that this needs to be a progressive and sustainable process as long as countries have the necessary resources. When the issue gets to court, the court believes that the lack of coverage of these medications, these drugs, shows reluctancy by the state to cover their obligations. And they interpret that because they don't have evidence to show that that they are being reluctant. So if we can show a court that covering this drug implies 88,000 years of life, or it implies that we are not covering certain gaps in terms of essential services, the legislation is very clear, as well as international treaties. The priority is this type of primary service. And the courts don't have the necessary evidence to understand this is not reluctancy by the state to fulfill their obligation to protect the right to health. It has to do with progressivity. They don't have the right evidence to be able to say whether this is a progressivity issue or not. Thank you, Cata. Natalia has raised her hand. Go ahead. I just wanted to add something to what Cata was saying. There is a mechanism that was created last year in Argentina, and it was roundtables. So before the legal processes started, the different parties can provide all the information through these roundtables, and that way they can make informed decisions. Courts do not have a comprehensive vision of the issue, which is very complex even for those within the health system. So we believe that these type of working groups, so to speak, could bring the different parties closer, and they could help the different parties understand each other, understand the information that is available. Thank you, Natalia. I don't know if anyone else would like to add anything. Javier, of course, go ahead. Thank you. To say something that I believe is truly important. I think it is very hard for our countries with the type of
simplemente no dar opciones de acceso a algunas tecnologías, sobre todo
wide access to certain technologies, especially in certain pathologies where there is no treatment options. So we need to talk to patients and healthcare professionals to be very explicit about what we are buying with that money and what opportunity cost that entails. Thank you, Javier, for your answer. There are many questions that focus on this issue. How can we manage the drugs prices? What could we do to manage prices? Specifically also orphan diseases, medications for these diseases, effectiveness of the national drugs funds. This is a strategy that is growing in the region over the last years. So in addition to what you have mentioned, are there other strategies that can be used in order to manage the prices of the drugs? I think, Javier, you covered everything. I think we have Pablo Barraban here, who is chief of the health division in the IDB, and he had a very interesting question. How can we involve society in these discussions? How can we convey this type of message and get everyone involved in this discussion? So who would like to answer this question? How can we convey the population this type of difficult decisions that need to be made by the government?
Yo creo que lo primero es hablar de cuánto estamos gastando en salud. Creo que eso,
The first thing is how to talk about how much we are spending on health. On average, $1,100 annually in the region, and in rich countries, it's more like $10,000. So it's important to see how much we're spending on health. If the population says that they need more money to be invested and better health, that's good. It's just a matter of seeing the percentage of the GDP that we're investing in health. There's space for growth. We're investing 5, 6%, and we could go up to 10% rather, but it's not easy. And then if we understand that we have specific budget, a limited budget, it's important to have social pacts in place. We cannot pay everything, and we cannot pay everything at any price. And I think Catalina was talking something about progressivity. If we show the gaps in terms of coverage through patients associations and physicians associations, they may understand that those coverage gaps are very serious and we need to bridge them. But right now, they're not so evident, they're hidden. And I think we are sometimes we get surprised when we say that 45% of patients in the region with HIV/AIDS does not have access to antiretroviral medication. So with the new technologies, we can improve the situation, but the conversation is not, no, there's no access. We need good access. So it's not that there is no access, there is access, but it doesn't have to be that way. It has to be better access. I would like to add two things that are truly important. One, transparency, and two, accountability of the resource allocation, because that gives legitimacy to the decision-making process that is very complex. So if our countries improve their accountability and there's greater transparency in resource allocation, I think that will also help with communication issues. Thank you, Natalia. Thank you, Javier. One last question that we have received. It has to do more with the methodology of the selection of the drugs that were used in the study, as well as the analysis. The question is the price, just the price, a good indicator to select these medications, or should we consider other categories in order to select the drugs for this type of study? Catalina, I'm going to countries don't have a high cost, and not so much the price itself, but per patient that is treated annually. And then the impact on the budget. What are the drugs that are absorbing the greatest amount of resources? It's not the same thing as prices. So it's interesting that we saw that some drugs that don't have a very high price necessarily result in a very big opportunity cost because the clinical benefits are very small and because they are given to a high number of patients. So price itself is not a good indicator. We need to see the budgetary impact within the different items when we choose that high cost drug. Thank you, Catalina, for the clarification. I think we're getting to the end of the session. I don't know if any of our panelists or speakers would like to make any final remarks. Good. Well, I'm going to close the session now. Once again, I would like to thank everyone for their presence. Catalina, Natalia, Javier, Dan, Ursula, thank you for your time. Thank you for sharing your knowledge and experience with all of us. Before closing this session, I would like to invite everyone. In fact, first, I would like to thank everyone for being here this morning in this very interesting session. And I would also like to say thank you or invite you rather to join us to the webinar that we will have in July, and we will share the studies of the results of the other two studies about the opportunity cost. These studies will be more focused on opportunity cost of assigning drugs, drugs that are of specific brand instead of generics. I would also like to invite everyone to join the MOOC course. It's a very interesting course about prioritization in terms of health as well as pharmaceutical policies. This is a course that provides us with the necessary tools in order to decide what to fund in terms of health and at what price. So we analyze issues that have to do with different types of policies to regulate, for example, prices such as joint negotiation, price regulation, transparency, as well as other things. I think you have the link for the course in the presentation that we'll be sharing. Thank you for your participation, and we will see you all in the webinar that we are holding in July. Thank you.